Okay, great. Well, welcome back everyone to another session of the Tortus AI Academy. And I shall also be controlling the slides. And it's my great pleasure to introduce my good friend and colleague here at Tortus and consultant nephrologist, Dr. Ellie Ascari. Hi, Ellie. How are you?
Hi, good to see you, Dom. Yes, good to meet you, everyone. Thank you very much for joining us in this lunch hour afternoon. We look forward to talking to you on the third session. Yeah.
So today's topic is understanding clinical risk in AI. Just a brief recap of the series so far. So what we're doing here at the Tortus AI Academy is a series for NHS CXOs and other digital leaders to better understand the LAI landscape, which is obviously increasingly moving at a very fast pace. There is a wiki, and I'll share the link after this to look back at the previous sessions, and you can also look at this session as well. Before Christmas, we covered what is AI, the very basics, and it's worth a rewatch. We will be revisiting some of those terms here again today. The last session a couple of weeks ago now with Dr. Sarah Gebauer, we looked at how to evaluate AI in terms of business case and efficiency savings. And today we're going to talk specifically around clinical risk. And just to remember, the goal of this series is not a computer science class. Many of the in-depth answers are very interesting and will provide some additional resources, but it's to understand the fundamentals so we as clinicians and decision makers can make better decisions about what clinical AI we're buying, implementing and deploying on behalf of our patients. And with that in mind, I will hand over to Ellie.
Thank you very much. So I think the clinical risk is a big topic, but what we're going to kind of go over today is to tell you a little bit about categories of clinical risk and some strategies to mitigate this, some conversation about governance and accountability, and some tips about implementation of best practice. So I think I think people who have joined this kind of meeting today probably do know that there are lots of benefits in using AI. There's a huge amount of promise in using AI to improve patient outcomes by improving decision making, the diagnosis, treatment plans, increase accessibility by using remote monitoring, enhancing patient experience. There's so much and different types of chatbots and different devices available for patients to use to improve their experience. There's a lot of cost saving to be had by reducing administrative tasks, by reducing patient readmission, by kind of monitoring patients effectively and not as regularly as we do in clinics. However, it's very, very important to do this correctly. We need to make sure that we do a clinical evaluation and demonstrate them and make sure that we identify the risk and mitigate them. So to increase the kind of benefits and also improve the confidence of people. This is a new technology and it's really important that we do it right so that increasing the confidence of users in this technology. So the various types of clinical risk, there's no kind of one way to categorize them, but we thought that we kind of discuss some of these, some things like diagnostic errors, therapeutic errors, bias and discrimination. Won't be talking too much about data privacy and security. That's a whole kind of area for itself, and it's not so much like a clinical risk, and a bit of conversation about the automation bias. So we'll go through some examples of each. So I don't know, so for one of the very important kind of issues with AI models is about potential diagnostic errors. AI models, if you can kind of listen to the previous sessions about evaluation and what AI is and how it works, you can, you get an idea about how AI models can misinterpret data, because that's what they do. They use a lot of data, they find patterns, and so that they can make mistakes, and then this can lead to misdiagnosis, make false positives or negatives, or incorrect risk stratification. I found this, you might have heard this example, is quite famous and people talk about this a lot because it's a really interesting point where the AI model was kind of developed to look for malignant or benign skin lesions like melanoma, or is a skin lesion malignant or benign? And what they found is that the model is working really, really well. And then when they kind of got into more detail, they realized that model is doing really, really well because it's picking up the images that has a ruler in it, because the dermatologists were using a ruler in the images that the lesion was malignant, because they wanted to see the size of the malignant lesion. Whereas for the benign region, they weren't using a ruler. So the machine was actually picking all the images with ruler and saying these are malignant, and without paying attention to the lesion itself. So you can see, if you think about how the machine is kind of identifying things, then you can understand how things can potentially go wrong. And I think as our knowledge increases about the use of AI and training models, these are kind of these kind of risks are getting less and less, and we can identify them and mitigate them a lot better. Another kind of really important thing is about incorrect treatment options. So I think that you can kind of think about many examples, but something I was thinking about, for example, in infectious diseases, if you think about it, every region has got their own infection risk kind of pattern. So even in the UK, different trusts, different areas have different kind of epidemiology with regards to what kind of type of bacteria is going around for urine infections, for chest infections. So if you train your model to pick up infections and suggest treatment in one area, and then you pick that up and use it somewhere else, might not give you the correct advice. Or, for example, there's so many models are being developed for identification of sepsis. And then it's kind of been seen that, say, for example, if your model makes a mistake and says this person has sepsis, this person doesn't have sepsis, and how that treatment offering could be kind of affected and can have detrimental effect on the outcome if you get it right, don't get it right. So this can be a model bias, as we have described. So it's very important to identify what data your model has been trained on, what the output is, and does it kind of fit into your certain population, and would it apply?
Yeah, that's really interesting. I get radiology actually in both of those examples. So the classic one with the chest X-ray evaluation was like, oh, we can age chest X-rays using the model, and after very successful training, realized it was just reading the date of birth at the top right. Had thought to take that out of the image. And the other interesting thing here is like, is it, there's adult chest X-ray reading technology and all sorts of other radiology. If you show an image of a child, it will make a diagnosis, but it's completely incorrect because of that.
That's right.
Training bias. I remember once walking into the surgical offices as an S1, and two of the senior regs showed me an X-ray, and they were like, "What do you think this is?" And it was a picture of like a curled up skeleton in a bigger whole body X-ray, and I was like, "Oh, the lady must have a cat on her lap or something." And no, she was pregnant. So even we don't often see images that we expect to see, right? So I was expecting there must be an animal in there, and it was actually a child, but I'd never seen a fetal X-ray before because it's not something you should see.
That's right. Yeah.
Exactly the same situation with AI, I suppose.
So I think kind of exacerbation of bias in inequality is one of the really important things that has been, you'll probably hear it in the media, in all the conversations about AI, and it's a real true issue. And I think one of the challenges is that we do know that a lot of our data, including our health data, is inherently biased. And so because of how society works, unfortunately. So I think there's already a lot of inherent bias within the data. And of course, if we're using that data to then drive our models or kind of make predictions, we need to be prepared that there will be some bias. And kind of being aware of it and making sure that we can, address it as much as possible is a very important topic. So I really like this study that was published actually a few years ago, where they, in the US, which is a very monetary health system, they try to understand if what groups of population require more healthcare, and they kind of found that the Black patients were requiring less healthcare, which is kind of, they thought of how is that possible? And what had happened is that actually the Black patients were using less healthcare because they couldn't afford it, and they actually were quite a lot sicker, and they kind of presented a lot later and had poorer health. And it wasn't because that they needed less health, it's because they weren't using the healthcare as much as they needed it because they couldn't. So I think it's just like, this is a really, I think, good example to think about when you see something you need to be very careful and question the output and say, is this really true? Does it actually fit with what's happening? Just because the machine said so doesn't mean it. So, and there are many ways that people are trying to mitigate this type of biases in the data. There's a lot of attention being paid to make sure that we collect data from kind of more diverse racial groups, and also be aware that, say, for example, if we are testing something and we don't have a representation of a certain ethnicity or a certain population, at least we can say, and disclaimer, we don't know if that model works exactly like we're saying. If we have tested it all on a certain group of people, it might not exactly work the same in another group of people.
I mean, the way I think about it is leverage. So used in the right way, you can massively exacerbate the positive impact, but equally in an ignorant way, you can actually massively exacerbate the existing negative impact if you're not careful about how you distribute it. And that example is a classic of the existing negative bias of American system and monetary access being then amplified in that sense by an AI algorithm.
Exactly. And I really like this automation bias. I think people, I mean, in general, we always say, oh, like human in the loop, and human in the loop is kind of solve all the problems that AI may have. So then, if you have a human to check the output, it's going to all be fine. But I think it's very important to have this in mind about automation bias. So clinicians, like not just clinicians, humans can be very much over-reliant on the technology, and can, after a while, they stop paying attention to potential mistakes. So I think this has been studied both in the clinical setting and in the non-clinical setting. There are several small studies coming out, say, that they test like small clinical scenarios and see how the doctors kind of solve the problem compared with AI, separately with AI, or AI on its own, and then comparing all these things. And I would say that the results are a bit like hit and miss. So in some scenarios, quite often actually, the doctor and AI work the best, but it is not always the case. And it's not like you would think, oh, it's improves huge amounts, because doctors at some point they get tired. Imagine if you have some kind of a model that reviews chest x-rays and makes very little mistake, at some point the doctor kind of loses the ability to pay the amount of attention that it requires. So I think there's this study that they did, actually a non-clinical one, that they found 49 experienced drivers to drive driverless cars for a week, for an hour, and then after a week, they see after a few days they realized that 80% of the drivers weren't paying attention to the road anymore. They were just watching their phones or reading a book or something. So I think humans are fallible. So I think it's really important to keep that in mind, and that's why and we talk about it in a minute, that constant evaluation, not taking your eye off the ball is really important in evaluating and checking the models.
I have to say, I agree with you. This is actually one of my favorite areas, because we know so little about this. We're just starting to see what does it look like when someone's worked with an AI system for a year. I mean, though, in the clinical world, that's only really existed for like the last 6-8 months. So even those people, how their behaviors changed, have they changed in a good way, have they changed in a bad way, how do they use the system now to how they started using it a year ago, and whatever that system might be. I got into a Waymo in San Francisco, to go to your point about autonomous vehicles. Yes. That was so funny. When the Uber driver, when the human is there, I'm really vigilant to be like, are they driving okay? Like, what are they doing? And actually, the Waymo drove really well, and I completely forgot I was in a car at one point. And then someone started beeping me, and I was like, I'm just sitting in this. I'm not driving it, and I was really like disconnected from the whole situation. And I thought, wow, that was such an instant behavior change.
Yeah,
we don't really understand. Well, we don't really understand why human clinicians would ignore AI suggestions. I mean, we have ideas why, but we don't know why. We don't know why they sometimes take them, sometimes don't. And we also don't know why they would ever rely on something. And I think that's something that we need to study, especially as the systems get more complicated and start suggesting guidelines or making diagnoses, in association with. How do they fit into the hierarchy of medicine? Does a consultant from the AI? Does a junior doctor learn from the AI? Like, how does it all fit together? I think that's something that we'll have to study quite extensively, as you say, continuously over the next decade or more likely.
Definitely. I think we need to really pay attention to this. It's kind of not very exciting and sexy. That's why it's not, you know, behavioral science, but people are generally more excited about the tech side of things, but it is really, really an important area.
For sure.
So can't kind of emphasize enough on this. So to kind of mitigate risk and to make sure that we kind of cover risk, rigorous evaluation is key. And that should be in all different kind of stages of any technology, before the deployment, if depending on the tool, if it needs clinical trial, not everything actually fits into the clinical trial, but depending on the tool, and the post-market surveillance. So these are very, very important. And some of the things that needs to be really considered, as I kind of mentioned it earlier, about the quality of data. I always think about what the AI tool that you're planning to use, what kind of data has it been trained on? Is it generalizable? And see how it performs in the real world and assess its kind of performance. In that, if you are to kind of procure or use an AI tool, in understanding the relevant regulations and ethical guidelines is really important. And I think since ChatGPT came out, everyone is, I think the conversations about regulations of AI has kind of gone through the roof, and there isn't any, at least if you're following the kind of this topic, there isn't any day that people are not talking something about the regulations of AI. And there's a lot of anxiety because it's such a new technology, such a fast development, and people are not sure how to go on about regulating it. But I would say if you kind of understand the regulation landscape of medical device, then it's kind of reassuring that these technology also fits in within the medical device regulation. And of course, there are some challenges because of the way how they develop so fast, that how we can kind of catch up with regulating it, something that people continuously talk about. But I think the foundation is there. It's just about a matter of how we can fine tune how to regulate to certain specificities. So in the UK, MHRA oversees the regulation of all medical devices. In the EU, Medical Device Regulation and the EU AI Act, that kind of has come into effect last year. And in the US, the FDA does the guidelines for medical devices. And of course, in addition to the guidelines, which to the kind of regulations, which are essentially law, means that we need to adhere to them, it's very important that we adhere also to ethical AI principles. And although ethics they're not part, some of them kind of have the foundations for the law, but they're not law in itself, but abiding by them and making sure that they're kind of the devices that we use fit in with that ethical principles is really important to build trust, to kind of in the population, to ensure that we align with the kind of the whole population or government's AI principles, so that we have a fair, we kind of abide by fairness, reducing bias, and all the things that an ethical society kind of tries to follow. If that makes sense. So what is really, really important, I think this is one of the most important slides about the kind of assessment of the medical device. So most AI, all AI technologies would fall into some sort of a medical device. And the definition of the medical device is really important. Whatever tool that you're using, it would be a medical device, whether it's a software or it's the hardware, that it needs to be a product that is intended for a medical purpose to diagnose, monitor, treat, alleviate, or prevent disease or injury. And so this definition is the key factor about what tool that you're using and how that tool is going to be regulated. And the classification, most places follow the similar classification that you see, like 1, 2, and 3, and 2 is like divided in 2A and 2B. And as you go higher and higher, the risk is increased. So for example, class 1 are kind of devices that doesn't require a notified body approval, because they're kind of companies that have a class 1 medical device, like they can self-report themselves by following a lot of regulations that are set by the NHS. It was NHS Digital, and now they've kind of merged with NHS England, with a lot of regulatory requirements that they can self-certify themselves. But as the kind of devices become more sophisticated, say, for example, if you have a pacemaker, that would be class 3, so it requires a lot more vigilant kind of assessment. But what is really important with the intended purpose, if you think about it, I mean, if, for example, if you have a watch that is a smartwatch, and you say that this smartwatch, I'm making this with the intended purpose just so that you can check your pulse, whatever you like, and check your activity or how much calories you burn, and that would not be a medical device. But if you have the same watch and say, actually, I'm making this watch and my intended purpose of it to find out if you have irregular heartbeat and you're at risk of stroke. So if that would be your intended purpose, then that watch then becomes a medical device and needs to go through all the regulation. So the intended purpose is a very important one, and to identify whatever tool you have, what kind of class of risk it has, would then guide you on what kind of regulatory approval you require and how you need to go on about it.
Yeah, I mean, this is another really fascinating area where the technology is moving faster than the regulators can keep up.
Yeah.
I think I agree with you. I mean, Tortus is a class 1 medical device for this particular reason. There is a structure, there is a evidence requirement, there is a process. It is imperfect, and actually a lot of the elements will need to be updated quite regularly as we move. And again, as the typical everyday AI that you're working alongside goes from class 1 to class 2 to potentially even further, this is the kind of rigor that we will need. Thankfully, seeing some AI innovation on the compliance side as well to be able to keep up with the documents. But I think more fundamentally, it's our understanding of what is and isn't a medical device is changing quite rapidly now. And AI is probably somewhere between a person and software, as opposed to purely software, which is very deterministic. Person has to be trained, it can make mistakes, it can have variable performance, and that stochasticity is something that none of these traditional ways of assessing technologies actually can account for today, and therefore you have to build evaluation. I think automating evaluation, and that's a big part of the scene outside of the medical space in the AI sphere, it's all about evaluation at scale, and that's how you get to enterprise grade performance, will probably have to become part of this. And my suspicion is it will all end up at patient outcome levels, as in, how did the patient do? Was there any patient harm? So the best definition I've heard for medical device, which is the simplest, if you're thinking of creating an innovation, if it goes wrong, will your patient come to harm, potentially? And if the answer is yes, then it's a medical device, and you just have to figure out where you are on that ranking. And if the answer is no, then you're building something for the consumer market and it's something else. But I think, while we're still pioneering, this has become a really interesting area, B, a potentially really hairy one as we go forward as well. And obviously somewhere we spend a lot of time at Tortus.
Absolutely. So the MHRA has had a roadmap, I think last year, and they've recently updated their kind of AI roadmap for medical devices, and they require several kind of many things, but falls into 4 categories. One of them is clinical evidence requirements. So you need to show, if you have a medical device, there is a scientific validity of it, how the clinical performance evaluation and real-world performance monitoring. For the technical requirements, you need to have some change management protocols. You need to have some data quality standards, cybersecurity measures. So, for example, your company needs to show that they're kind of follow the guidelines for the cybersecurity. They're not non-penetrable, comply with GDPR, comply with data processing, all the different requirements. You need to have a risk management. I think anyone who is kind of using any medical device probably would be familiar with it. You need to have a clinical safety officer to do a clinical risk management forms and have a hazard log and go through all these processes, continually doing risk assessments, do a benefit risk analysis, do a post-market surveillance, and there's many documents that are required. I think even for a class 1, there's so much documentation that required, and there are companies that help with that, and most places that you are going to be using medical devices, you would need to have some kind of regulatory expert to kind of help with this type of document gathering and evidence gathering and being able to look after all of these elements, because it's quite comprehensive and extensive. So I think in a way these are all already in place for medical devices, and AI has some slightly different capabilities and capacities, but these fundamental things are there already that they need to be complied with.
It's a great forcing function, actually, as painful as it is for startups.
Yeah.
Once you've gone through these processes and you put them in place, you've created a culture almost by design where you have to maintain these documentations. Therefore, we have to look at processes. Therefore, we have to continually test. Therefore, safety becomes part of the DNA if you want to get to market in this way. And I think that's exactly why, even if they're imperfect, this is definitely the way to go forward with any AI technology, I would say.
I think it's really good when you actually do it, as you say, Dom, is that when you try to fill in the hazard log, for example, it makes you think a lot. What if, it makes you think about a lot of risk that you wouldn't have otherwise thought about. As you were saying earlier, like, what would my patient come to harm? It's something like, oh, how about if it comes to, what would happen if, for example, an AI script say something wrong? And we've talked a lot about this, like, at what point would you consider it as a harm? So we can standardize risk estimation based on the probability risk and the probability of a risk and how bad the consequence of that risk will be. So with harm, we mean that if somebody, some injury happens to a person. And so say, for example, this is kind of one of the things that I find is in some cases not so straightforward, because some of it can be slightly subjective. So I think people's kind of understanding of risk is a bit different. I think that in itself is a science of how individuals perceive risk. So, even in the general population, I discuss with patients, if I want to do a kidney biopsy, say if they are kind of, say, 1 in 100, they need a blood transfusion. I think some people find that really like shocking. Some people find that it's fine. So it's really interesting. But essentially, that's how one of the kind of key ways, the matrix test that we use to identify the estimation of risk based on the likelihood and consequence.
Yeah, again, imperfect, isn't it? It's all context specific.
Yeah.
When we used to do risk assessments in the cardiology land, like cardiothoracic bleeding, catastrophic bleeding is like the aorta's hosing everywhere. That's catastrophic. Whereas catastrophic or severe bleeding in when you do a cath is like, you get a hematoma here or here that you can't control. And it's a very different level of risk, but equally those events should be very low relative to the danger of what you're trying to achieve. And that's why I think this is probably like it's a very transmutable way of talking about risk, but equally it's actually quite difficult to then make those decisions. And that's why it's useful to have, we're both CSOs, have an external CSO, talk to the CSO in the hospital as well. I think one of the things to stress here is to make sure that when you're adopting a new technology, those hazard workshops that you're supposed to be doing actually do get done, because the subjectivity of what is and isn't significant can be quite variable, and your risk tolerance as an organization might not be the risk tolerance of the organization down the road, for example. And there's lots of inherent interesting things that can come out of those discussions anyway. Use cases, intended use, better instructions, better training. So well worth doing that as an exercise.
Absolutely. So I thought I'd put this question out to the audience and saying, so if you have an AI radiology tool that says lung cancer, you have that reports lung cancers that make mistake 1 out of 1,000, how would you categorize the risk? I mean, which number would you give it? I'm just curious that if everyone would think about the same risk. Say, for example, if 1 in 1,000, it misses.
Yeah, so interesting. How would people categorize that? So a radiology tool misses a lung cancer on some sort of scan.
Yeah.
How would we think about that in terms of impact? Is that minor, significant, considerable, major, catastrophic? Could do with a poll really, but you could
Yeah.
put your answers in the
If you put your number in.
So we've got one vote for 4.
Yeah.
Which is confusing. Stephen, do you mean major or do you mean likelihood high? Like, or you categorize that on the numbers there, I suppose. Yeah, interesting to break it down. So also, I guess likelihood is also subjective, right? So what is 1 in 1,000? Is that a very high likelihood, a high
Yeah.
likelihood, medium likelihood, low likelihood, very low likelihood? For example, 1 in 1,000 might be considered very low if the AI radiology tool only looks at 100 scans a year. If it
Yeah.
looks at 1,000,000 scans a year, 1 in 1,000 suddenly becomes almost a daily event.
Yeah.
So how do you assess likelihood as well?
Yeah.
So
I
this
think
is
it's very difficult.
likelihood, low, medium, catastrophic consequence. Interesting. So yeah, that would come as a 4.
Yeah.
Whereas we've had some disagreements already about the impact of the risk. I think this is really good to highlight like how difficult this actually can be.
Yeah.
And again, depends on the context. So for example, if the AI radiology tool is an overread and there's
Yeah.
2 steps and the human's in there, then you can massively decrease the risk, right? In this scenario, if it misses it and the human picks it up, then the risk is significant, but it's not going to cause the patient significant harm because there's a second line. Similarly, the number and the context become very important. Adele says major 2 catastrophic, reasonable high. How do you feel that has that 1 in 1,000 had their fatal neoplasia missed? Depends on sample size. Looked at as risk relevant to current situation. Is it better or worse? I mean, that's a very good point.
Yes.
So when we talk about AI technology, one of the things that we rarely talk about is what is the baseline?
Yes.
And actually that from Kate is a very good suggestion that maybe
Yes.
we should start. And I think I made this point to you a couple of months ago, actually, when we were looking at this, like what is the relevant baseline of risk today? So for example, for ambient, if you miss how often do human physicians miss important details that could potentially change the diagnosis from what they document? I don't think we actually know that. If we did, then baselining and the performance of risk would be much easier if it's safer or worse. And I guess similarly here, like if the lung cancer is missing 1 in 1,000, but the human radiologist was missing 1 in 200, does that make us look again at this table? And I think that's what I've always found tricky about this process is it's kind of a static one when really it's the dynamic relative change that is what we should be paying attention to, especially when we're trying to achieve something in the organization or in the clinic.
Absolutely. And I think all the comments that people are making is actually quite valid. And I think it's important to have the baseline, see what the rate is in the organization already with the humans. And of course, that really helps us. And I talk about it a bit later about the question to ask, what level of risk are you happy to accept when you kind of trying to use an AI tool? And then that helps you communicate that with your patient as well, because they're one of the most important stakeholders. Yeah, so I think I just wanted to bring that it's not so, in here. So I think, human stress, I think, so much happening. So just wanted to make a point about the EU AI Act. A lot of people have been talking about it. It took a long time for the different EU countries to come up with this regulation. And what they have done is also a risk-based assessment for the AI technologies, which includes medical technologies, and this is all AI technologies, and it comes from minimal risk at the bottom, which is like spam filters or video games, which goes higher and higher, which the unacceptable risk is social scoring or face recognition. And you can see that this is kind of different from the US, for example. They use in their airports facial recognition, which I found quite interesting after studying the EU AI Act for a long time. And when I went to the US at the airport, and I was thinking, how is it that they're just letting everyone have their facial? So it's very different. And EU does have like a lot more stricter regulations, but the medical devices fall into the category of high risk. So I think they need to go through a more rigorous process to get to be able to be used. However, and there's a lot of discussions about, what is the best approach, because some people think that AI is very limiting because it has a tough regulation and it doesn't let innovation flourish. And some people say, well, in the US, the FDA has a lot lighter approach. So people say that the US is a better place. And I think UK is trying to kind of take the sitting somewhere in the middle to have a good kind of safety approach, but also allow for innovation. And I think that's probably a better way forward in a way. Difficult to know. I think time will tell.
I think it's a more sustainable way, and obviously, you know,
Yeah.
the latest administration in the US have just sort of slightly deregulated again.
Exactly.
But I think the fundamental interesting thing about that is it's an extremely litigious environment in the US. So as deregulated as you want to be on the innovation side, when you come to
Yeah.
deploy, you are then entering one of the most high-risk clinically medical legal environments in the world in terms
Yeah,
of how easy it is to sue
that's
everybody.
true.
So like AI companies who are going, oh yeah, we're just going to deregulate and run straight into hospitals are going to be woken up very, very sharply to the
Yeah.
fact that, you know, clinical, medical legal litigiousness is not going to change and probably will get worse in the world of AI. And so actually this is the type of stuff that I think in the limit will actually give EU companies an advantage. Growing up in this environment and growing up hard, as it were,
Yeah.
in the clinical regs, mean
Yeah.
that when you go over there, you can have high confidence in your systems and you can evidence that, and that becomes defensible in that legal environment. And I think the FDA, slightly aside, will maintain a lot of standards around medical devices. But equally, who knows in terms of what gets deployed and how it gets deployed. I think it will be the Wild West until it isn't. That's generally my view with most of these industries, especially in medicine. It will persist with, you know, relatively light touch until there's an event or there's public interest in the protection and the safety. And then, you know, those of on the right side of the regs of the medical devices will be the ones that persist and are sustainable as companies and innovations. Anyway, that's my view.
Yeah, I think time will tell. So how do we mitigate clinical risk? I think is a continuous cycle. Like any other medical device that we've been using, it's very important to identify and monitor, assess and monitor risk regularly, making sure that there is a robust risk management process in place, governance process in place, make sure that we do clinical validation and pilot studies, checking if the company has done any real-world testing and if they needed to do any clinical trials, depending on the device, have they done any real-world kind of testing and assessment, and what is their result? Very important to have kind of interdisciplinary collaboration, have the engineers, the clinicians, the governance team engaged together to make sure that people know the kind of pathway of how to report incidents, how to raise issues, where to get that fixed, and also continuous performance monitoring and ensure that post deployment you have an eye on it. And we've been emphasizing this throughout the talk, that is one of the main or most important things to ensure that safe deployment of a AI tool, whatever that may be. Yeah, I think this is one of the issues that I don't know how we're going to address in the UK, and that's upskilling of staff. I think, in my view, the knowledge for AI is kind of way behind how the technology is progressing. Unfortunately, the situation with clinical teams is that everyone is so busy. It's really hard to make time to kind of put in this education. But as far as I know, there's now in the curriculum for medical students to learn about AI. But I think that's going to take some time before they come into clinical practice. But for the time being, it's really important that the clinical staff have some basic data literacy, some basic understanding of AI, how it works and its limitations, so then they know what to look out for. It's very important that there is collaboration between the data scientists and IT people, and regular training, because these AI tools are constantly updating. Things are changing so fast, it's really hard to keep up. So it's really important that regular updates happens. And I think sometimes we underestimate the change in the workflow, and we were talking about it with regards to the human-computer interface or human AI tool interface, and how we don't know how it works. So I think with any tool that you implement that is going to affect the workflow, we don't know how that influences the whole dynamic of the clinical care that people are going through. So if you have an AI technology that helps with reading X-rays, how is that going to affect clinician? How is that going to affect the workflow? Would the clinician then be asked to see more, review more X-rays? So I think one of the things I heard from some radiologists is that what they were saying, so if I look at, say, 100 X-rays, and if they're all, like, say, half of them are simple, half of them are hard, and then you put in an AI technology that looks at all the easy ones, so then the head of department can argue, well, I've taken off this 50 easy ones, so then, or 50 off, they wouldn't say 50 easy ones, they would say, I took off 50 off your load, so you need to look at the other ones. But if they're harder to kind of look at or more difficult to analyze, then how are we going to kind of factor that in? How are we going to put enough time for the radiologist to be able to? And of course, that cognitive load as well, which is we don't kind of pay attention to. If you're going to analyze a difficult X-ray, it's harder for your brain, so it takes a lot of time. So maybe, it's just a lot of nuances that we don't know until we kind of pay attention to it and take the factors in.
It's such a good question, and I think that probably why the impetus for starting this webinar in the first place was the fundamental of like the gap between what we know in deploying AI today versus what we knew 6 months ago versus what we know 12 months ago is vastly different, and it's full-time working on clinical AI every single day, right? And then we talk to people and they're like, oh, can you do this thing now? Like, yeah, we could do that 8 months ago. The technology is moving so fast. But I think it's not just clinicians. And I think interestingly, this is one of those innovations that shouldn't live in the innovation department. It shouldn't live in the transformation department. Everybody is going to have to understand some of the basics of how this technology is going to change, not just healthcare, but so many other parts of our society. And actually already persists, autocorrect on your phone, that's AI. The way that you open your phone when it recognizes your face, that's AI, right? These are technologies that already we're kind of familiar with, but I think pitfalls are new, the limitations are new, some of the edge case behaviors like hallucinations, for example, these are new terms that I'm really keen to understand. I think your point about workflows is exactly right. Like the technology is just the technology, but it's the product solving the problem. So what is the problem, right? Radiologists don't have enough time. And then you go through all the steps and you realize that you've actually landed them with less time to do the important work, even though you've moved the workflow around significantly. And I think that's something that we need to be super conscious of. If you don't have a problem across the workflow, sometimes, for example, and you say this all the time, AI is not actually the right solution, or it's actually going to make it worse. It's going to amplify the problem in the wrong way. So like diagnostic screening algorithms sound great in, the Daniel Ek, the box where it sort of gives you an AI-based diagnosis. That's great. But like, who's going to deal with the white noise that then creates in the system downstream? Because it's not going to be the NHS for sure. It's already full of actual patients who are actually unwell, who already have symptoms. What do we do with the walking well, who think they may have a problem, and we don't actually understand the data behind it either? So these big system changes, they'll come, but we need to sort of manage them through very carefully. And I think that's where a lot of the value will be added, or in fact detracted, by deploying AI in the right or the wrong way, respectively.
So there's a lot of kind of questions about accountability, I think, whenever AI tools are being used, and people ask a lot of times, so what if we buy a tool and then it just makes mistakes? Who's going to answer? And I think there's no kind of right or wrong or definite answer about it. I listened to a recent podcast that Annabelle Painter at the RSM with a lawyer who was talking about this accountability issue. And it was really interesting that this is a lawyer who does a lot of mitigations, like negligence cases in the NHS. And what he was saying is that he hasn't come across a case yet against an individual with using AI technology. But I think it's probably not going to be too long before probably a case comes about. But in the answer to the question of who is accountable, I think there are different levels of accountability, and everyone, different people are different for different aspects of it. Ultimately, if a clinician uses an AI tool in the clinic, they are responsible to check the output. So if I use an AI scribe, I need to check the output. If I use it to check an image report, I need to make sure that I have checked if I agree with the result. The organization needs to have an oversight of the device to make sure that they've done their checks with the provider. They've got a clear governance structure in place. They know how they can train the staff. They can let the staff know how to report incidents. And there's of course the technical accountability. So if you buy a tool from a company that says our kind of accuracy rate is 90%, and then next something happens with the model that they're using, and the next thing you know they're 50% accurate, they are responsible as a provider to give you a device that is good. So each person, kind of different people are different are accountable at various stages of the AI journey. So implementation and evaluation go hand in hand. Some good tips for practice. We've been through this throughout the talk, but it's good to start small and iterate, see how it's working in a small group, make sure that you can iron out any problems. You don't suddenly roll it out in the organization and see if it's not working. It's quite obvious. Multi-stakeholder engagement. I would emphasize involving patients very early, because that kind of helps you with getting confidence, getting their views, and see what's tolerable and what's not, what's acceptable from the patient's perspective. Having a robust project management in place and continually improving by learning from what didn't go well. Did I not communicate with my staff well? Did patients not like it? Did the microphone not work? Did I have the right things in place to make the most out of the tool?
100%. Okay, great. Oh, is this your last slide?
Yeah, so this is the last slide. So questions that you need to consider when you're thinking about clinical risk. You need to, as an organization, Don was saying earlier that different organizations might accept a different level of risk. So what is an acceptable level of risk that your organization is happy to take? I think that's something that you need to be clear. Who is responsible for the performance of the device? So I think it's really important, and I'm sure most organizations have this when they procure a device, that they kind of have an agreement with a provider to say who is responsible for which bit, who is going to follow up, and do you have a plan in place when things go wrong? And I think that's the key for the governance structure for the risk assessment. So I think we've gone through this. Key messages is that rigorous risk management is important, strong governance is important, and continuous monitoring is very important.
Yeah, awesome. Okay, well, thank you so much, Ellie. Let's go through some of your quiz and see how much the audience were paying attention. So if you've done this before, you'll see that there's now going to be a poll that you guys can answer if you look at polls there on the live storm. So automation bias is defined as one of the following: tendency to accept computer-generated recommendations against your own judgment, a tendency to ignore AI recommendations due to past experiences with technical errors, a preference for using the newest AI technology over older systems. So you can have a little of a vote. We've got a few votes in there now. If you manage to find the poll button, it's just on the bottom right. I've also heard this called reliance bias, and maybe in the future we'll have other categorizations of this type of human-computer interaction issues. One of the things I've also seen, which we don't really have a word for at the moment, is the loss of your own ability to do the 0 to 1 thinking that you require. We see your autonomous vehicle is quite accurate. I've seen this also in writing. I used ChatGPT for a while to do some writing work, and then about a month in, I was like, I can't start something myself now, so I had to stop and start again. That switch is in your brain. It's a muscle, right? And it's the muscle that causes this kind of problem, and we need to understand that clinically. Great, yes. So most of you put down that it is indeed the tendency to accept computer-generated recommendations, and something that is an interesting area to study, and we should probably start studying it quite quickly. A quick one: which organization oversees the medical device regulation in the UK? So let me just publish this poll as well. You should be able to vote for that one as well. So again, a slightly transitory one, as things are changing a little bit. But the answer we're looking for is who is the body to look for today. So if a vendor comes to you and says, we're a medical device, where should you go and see if they're registered? And yeah, so most of you have said the correct answer, which is indeed the MHRA. And if you see a vendor and they're a medical device, go to check them out on the MHRA website. and see if they're registered there. And then last but by no means least, and this is a hard one because I've noticed I've been putting 2 easy questions here. Which of these are considered high risk by the EU AI Act? So chatbot interactions, emotion recognition, or justice systems? Let you have a little bit of a think as people go through that. If you remember, there was unacceptable risk, high risk, sort of moderate risk, and no risk. So a few people, lots of don't knows, I'm guessing, because only 4 votes so far. So the answer is actually justice systems. And I think the EU very much is thinking about the impact on society as a whole with their legislation. There's a lot of interest in things like facial recognition, emotion recognition, of tracking individuals. And I think the EU is very nervous about that. And that actually is a bit of a differentiator in terms of how people are going about implementing AI technologies in society a little bit more broadly. Awesome. Well, thank you very much, Ellie. I'm going to leave the floor open a little bit now for some questions. Oh, I didn't change that last slide, so let me just go back there because it still says the wrong person. But we'll stop sharing there and we'll leave it open for questions from the audience. So there's a question button. You can press question and ask new questions, and they get logged actually. So that is the most useful way of asking questions, because then they'll go into the replay and we can store those, or you can just stick them in the chat. And we'll wait for any interested parties to do that. Or we just cycle back to the beginning of this presentation. We can leave the opening slide up nicely. Perfect. Any questions from the audience at all? Stephen's typing. Let's see what he is saying. Or you can put it in the question chat. Oh, this is very interesting. Thanks very much. I have one question. Like, adoption is pretty low at the moment, but let's flash forward to, I don't know, 2 or 3 years' time, where co-working with some form of AI is like the norm for most clinicians most of the day. What do you think the biggest risk is if you were to worry about one thing more than anything else?
De-skilling, I think, is a good one.
Interesting. And what do you mean, like diagnostics?
Yeah, it is. It's kind of exactly as you were saying about using AI to ChatGPT to write. I mean, I find the same because I use ChatGPT and Grammarly. I can't now write a text message without checking with Grammarly to see if I'm doing it right. So I think it's like becoming really dependent on the stuff. I mean, imagine if you have like a machine that does a lot of things for you, then exactly as you say, it's like a brain muscle that might kind of make you de-skilled. I think that would be my main one. And of course, the question is, how are we going to then keep up with the update of the stuff? That's another kind of big problem, that the AI models are improving so rapidly. How are we going to keep up with the improvements? Then we're going to be stuck with one while something else is going to do better. So it's it's the constant iteration.
Yeah, no, I think the de-skilling one is one I'm particularly worried about. There's a question here from Adele. She asks, I come from the veterinary field where there is no regulation of medical devices. How would you approach ethical and responsible AI adoption in the clinical setting where there are no guardrails?
Is that you with regards to the animals? I think, to be honest, I'm not familiar with kind of what regulations exist for the animals, but I'm pretty sure there would be some. I mean, there's lots of kind of issues about how to look after the well-being of animals, different organizations. So I think if the AI does come into effect, you would expect some proper regulation, as in law, and ethical standards where you would need to have animal welfare in place. But that's a good question, and I think I wouldn't be like in a perfect position to answer because I'm not familiar with ethics and regulations with regards to the animal welfare.
No, 100%. I think the model is similar to the model that we've taken, of like consciously make a decision that this is an ethical, powerful, and dangerous technology, and then apply your judgment as best you can. And the vendor or whoever you're, buying from's, what evidence do they have? How significant is it? And there may not be a framework for that, but again, that's maybe where clinician role comes in more than anything else. If you're applying something to your patient in front of you, or your pet or your animal patient in front of you, equally so, there's still a duty of care in that sense. And I think that's probably the only way that we can do this. And then obviously, lobbying for some framework or answers to come quickly. Stephen Howe asks, are there studies looking at the impact on seniority of clinicians or any industry using AI on de-skilling?
That's a really good question. Not so much on de-skilling as yet, but there's quite a lot of studies looking at clinician age based on how they take on the AI recommendations about adoption of AI technologies. There's this kind of, and some studies suggest that more senior clinicians are less likely to adopt AI because they feel like they know it all. Either that, or because they're kind of a bit more old school and they don't use AI technologies as much. But there are some studies that actually have shown that more senior clinicians are less likely to make mistakes because they are more confident in their own clinical judgment. But I think with de-skilling, I think we need a bit more time because the adoption has not been long enough to then study the de-skilling of the clinicians. But I think that would be a really good thing to understand.
I would also kind of love to understand like the AI interaction that's required to not de-skill you. So like you can imagine a world where the AI is like, I know the answer, but what do you think? Right? Like it's very much like active teaching in the same situation. And I can see that for juniors for sure. And I think we have to take that super seriously. Otherwise we will accidentally wipe away all the existing algorithms that we have out there, which are all the humans, 40 plus years of clinical experience per head at some of the top level consultants. And we will just wipe all that away. And equally interestingly, I think AI as a consistent source of information is really important when humans are very inconsistent. So how do we marry those two things together? And it's a question that I think we'll have to answer. I'd love to, if you're interested in doing some research in the sim lab, I've got a whole bunch of experiments that I'd love to run and we haven't had time to think about them. Okay, well, we're over time. I just checked there's nothing else in there. Thanks so much for your time, everybody. Just to remind everybody again, so the next session will be in a couple of weeks' time. It's about driving adoption in clinical eyes, a very different tact, but adoption is pretty critical when you decide that you want to get something, to get it through your organization. If anybody's trying to deploy technology that understand the pains, and AI has some unique and some non-unique elements of that. I'll be hosting that with Dr. David Trisker in a couple of weeks. So thanks very much all again for your time, and we'll see you next time.
Thank you very much, everyone. Bye.